Good morning. I think we're going to go ahead and get started. I'm Karen Thomson. I'm one of the anesthesiologists and the medical director of our Perioperative Care clinic. And Matt Oetgen and I are going to be speaking with you today. He's the chief of our orthopedics division. We had Tony Sandler, who's our leadership in the surgical center, ready to come and introduce us a little bit more formally, but he is actually also the surgeon of the day and is caught in the OR right now. So we're going to get to the heart of the matter. And what we're really happy to be here today to share with you is a fun project that we've done over the last year to create a new care model here, something called the surgical home. We did it with our spinal fusion patients, people who had the diagnosis of idiopathic scoliosis. And we did it as a method of moving towards value-based care. So although it's a surgical program and a pilot program, we hope that you guys are able to learn some of the process that we went through, and we're excited to share our success. We have no disclosures. In terms of learning objectives, what we'd like to do is for you to come out of here knowing what the surgical home is, to understand kind of the analogy between the surgical home and the patient-centered medical home, which is something that did originate in pediatrics and I'm sure you're more familiar with. To understand how we used an enhanced recovery protocol. The main goal is really to shorten the hospital length of stay, but it's important to realize we're not just booting people out of the hospital earlier, we're actually helping them recover faster. And how using an enhanced recovery protocol really improved our patient outcomes and the value of pediatric orthopedic surgical care in this population. And then discuss how the transition to value-based payments can and will serve as a driver for similar type of quality improvement work. And now I'm going to turn it over to Matt and come back for the second half.
Thank you very much. So I think that this is a sort of familiar slide to everyone in some way, but it sort of sets the stage as why are we talking about this, why is this important, and why is payment reform an important topic. And I think this paints the picture, and what we see on the bottom is the share of the national health expenditure of the GDP. And as we can see, back in the 60s, it was fairly low, 5%, and you see this exponential rise in how much we're paying for healthcare. And there are multiple factors that play into this and multiple sort of factors of social and political reasons, but I think really it's all about the money here. I mean, it's the bottom line when you get down to it, and our healthcare expenditure is rising so fast that it's unsustainable, and so there's a reason to really start to reform and come and figure out what we want to do. Now, this is probably okay if you're doing this and you're making health better. People are living longer, babies are surviving longer, you're doing better. Everyone would agree if you're paying more for better health, that's okay, but we're not doing that. This is sort of a busy slide, but it basically shows on the y-axis here health expectancy, healthy life expectancy, so how healthy you are, and on the bottom you see how much you spend. And this red line is sort of a linear relationship of what you see in Europe, okay? As they spend more, their health gets better. And so countries in Europe, as they spend more, their health gets better. And what you want is this at the top left corner where you're not spending very much, but your health is very good. And you can see the United States way out here by themselves. We're spending a lot of money and not doing very well in terms of our health expectancy. And there's lots of these graphs. You can put it to survival of infants, you can put it to health expectancy, you can put it to a number of different things, and it all pretty much stays the same. The other thing is that the size of the circle indicates how much is public versus private finance. And so we have the largest circle, meaning we're paying for this in a private manner, which should allow you to get more service and better benefits, but we're not. So we're failing on multiple fronts. And so obviously the system has to be revised. We got to get over here where we're spending less and getting good, healthy outcomes. And so how do we do that is the question as we move forward down the line. And so this brings up this sort of concept and this buzzword of value-based care, okay? Value in medicine is defined by this simple term. It's quality of the care you're providing over the cost of the care. So to change value, you need to increase quality, increase the safety profile, increase the patient experience, whatever you do to measure quality, and you need to reduce the cost. and that will improve the value of your care. And that's what we're striving for as we move forward. That's the sort of bottom line with medical reform. So that's all well and good, big concepts, really good buzzwords. You can make a career by talking about this, and you look smart, and you talk about Europe and all that sort of stuff. But how do we do it on an individual basis, okay? How are we going to do this here? How are we going to do this countrywide? And that's a good question. So in 2008, if you go back to that, I think everyone can remember we had this big economic crisis. I was a fellow in Dallas. That played out in that we had a morning conference every year, or every day we had a morning conference, and they stopped providing coffee. And so it really hit me hard because I didn't get coffee every morning as a fellow. But that's just a microcosm of, you know, what we went through. And so in 2009, they passed the American Recovery and Reinvestment Act, so the stimulus package, $8 billion of stimulus. Part of what came out of that is the establishment of the Patient-Centered Outcomes Research Institute, PCORI, which you've probably heard of. It's an institute which was established to try to figure out how we're going to improve value in care. And so as they established that, they've tasked a number of agencies to say, okay, we've established this, we've funded it. Now, what are we going to do? What are we going to look at? And two agencies looked at this, and the Institute of Medicine came up with a list of 100 topics that should be targeted to increase value in medicine and care here in the United States. The problem was not many of them were pediatrics, and the ones that were very, very broad and sort of not very ripe for research. So another group up at CHOP looked at a big database and looked at a number of different things and came up with the 50 most expensive and prevalent conditions in pediatrics as a way to sort of better define what should be looked at in pediatrics in this manner. And this is what they came up with. They looked at prevalence and cost and variability of care, and these are the 10 most expensive conditions in pediatrics. And what you can see is 3 of them are surgical, okay? Idiopathic scoliosis, hypoplastic left heart, and adenotonsillar hypertrophy. So those are surgical. Those are ones that at least I can wrap my head around because I'm a surgeon and they interest me. And so we decided as we sort of went into this to say, well, let's look at scoliosis, let's look at fusion because that's what I do. And so let's take a little step back. Where are we with scoliosis? So as you all know, scoliosis is a curvature in the spine over 10 degrees. The prevalence is about 2 to 4% in kids aged 10 to 14 years old, okay? There's about 20 million kids aged 10 to 14 in the United States. And the prevalence of progression to surgery is only 0.1 to 0.3% of those kids, okay? So in the grand scheme of things, when you sort of get your math down, we're talking about 4,000 to 12,000 spinal fusions a year in the entire country. So how can 4,000 to 12,000 procedures get you 5th on the list of most expensive procedures that we do in the United States, or most expensive conditions that kids see in the United States? Well, that's because the cost of surgery is so high, okay? We're spending a tremendous amount of money on these 4,000 kids. And so this is a pretty ripe topic to say, someone's going to look at this and say, this needs to change, okay? So why are we spending so much money? Well, this is the 1930s, okay? You have a curvature, and the way they treat it was they hung you up in this traction, this Risser traction they called it, and they tried to stretch out the curvature, okay? And then once you hung up in the hospital for about 2 weeks to sort of loosen you up, they took you to the operating room and they put you in this body cast, okay? And then once you got used to that after about a week, they cut the cast and put a turnbuckle on the cast right at the apex of the curvature, and over the next few weeks, they turn the cast to correct the scoliosis. So now you've got a pretty straight spine. Then they brought you back to the operating room, cut a hole in the cast, opened up your back, fused the spine by putting bone graft in right where it is, closed the cast back up, and then you stayed in this cast for about 9 months while everything healed up, okay? So that's the 1930s and through the 1950s. High infection rate, fairly low patient satisfaction, as you could imagine, and fairly low correction rate, okay? But that's what we had. And then in the 1960s, a guy from Houston named Paul Harrington came out with what we call the Harrington Rod, okay? Revolutionized scoliosis. This was a rod, very simple device where you put a hook at the top and a hook at the bottom, right in the concavity of the curve, and you just stretch the spine out, okay? And if you put it in the concavity of the curve, obviously it would stretch the spine straight. So now you have what we call this internal fixation. At the very beginning, they still put the kids in a cast, but now they're only in a cast for 3 months to let this hold up because you have this thing. Worked pretty well, revolutionized surgery, and but there were some problems with it. Okay, it made some technical problems with the way the spine was aligned. So as things evolved, then in the 1980s, 2 Frenchmen, Cottrell and Dubuisset, came out with a segmental instrumentation system where now they use multiple hooks and some screws to fix at different levels of the spine and put 2 rods in. Much more stable, didn't need a cast anymore, much better correction, worked very well, okay? As things go on, people continue to develop. Now we have the current system where we use mostly screws where we attach to the spine. We can get much better fixation, much better correction, straighten the spine out. We don't need any sort of cast or bracing, and kids do great with that. So this is where we are now, big leap from where we were back in the 30s. But with that comes some downsides, obviously, okay? This is sort of busy, but I'll walk you through it. It's an important paper that was just put out. So this is the number of discharges per 100,000 people in the United States. And this black line right here is the number of fusions for scoliosis that we do each year. And you can see over the past, over 10 years, and it continues into the future, as we said, there's only the pie is only so big. There's only so many kids being born, only so many kids with scoliosis. So we're doing the same amount of surgeries each year, okay? If you go over here, again, here's the black line. This is the hospital cost for the surgery. And even though the numbers are staying the same, the costs for the surgeries are increasing rapidly, okay? This right here, this dotted line is pneumonia, very high number of cases, but the cost stays the same. Same thing with elbow pinning. Stays the same and the cost stays the same. But in scoliosis surgery, the cost goes up. So why is that? Most troubling to me, and should be troubling to you, is this sort of semi-dotted line. That's how much the surgeon gets paid. It's relatively flat, even gone down a little bit. So I'm not getting paid more to do the surgery, so I'm not the reason why this, well, I'm part of the reason why this is going up, but not in my pocket. But you can see the cost of the implants are increasing, the cost of the hospital stay is increasing, and so as we move from the Harrington Rod to this current state where we can make the spine super straight, we have done so at an increased cost to society, okay? So we are causing the problem in scoliosis. We're driving this small number of kids up to number 5 on the list, and are we doing what's right? Again, there's 2 sides of the coin, okay? This is fine if you're making kids better, okay? So are we making kids better? Well, certainly they're better than the 1930s. I think everyone would agree with that. But are they better than the 1980s or the early part of the 1990s or 2000s where we were using less when we were down here? I don't know. So let's look at the outcomes. Well, we know that we can improve the radiographic measurement. So from Paul Harrington's day where he left a little bit of curve to now where we can make it totally straight. We certainly can make the x-rays look better. You can puff your chest out and you can show the parents and you look like a saint. But does that really translate into anything that matters? Well, the patient-reported outcome measures, pain, quality of life from the SF-36, the scoliosis-specific measurements, they're mostly the same to age-match controls, to people that are just treated with bracing, and even people that follow their scoliosis up into the 60s and 70s, which never had it treated, they're relatively the same. So the patient-related outcomes really haven't changed much depending on what you do or what kind of instrumentation you use. So you can sort of cross that out. So how about the cost of disease to society? Well, there's some increase in chronic back pain if you use a little less technical instrumentation, but there's really no differences in ADLs. There's similar ability to work, marry, the amount of depression in these people. So really, we haven't changed very much of the cost to society. We have decreased the length of stay, obviously, from the 1930s to now, but I would say that from the 1980s to now, there's just been a very moderate decrease in the length of stay. And then complications, which is sort of too bad here, but if you look at the data that is collected by the Scoliosis Research Society, we really haven't changed anything in terms of infection, neurologic injury, fatal complications over the past 10 years. Now, they're fairly low to begin with. It's a fairly safe procedure, but we haven't really moved the dial on that either. So what have we done really over time? So again, let's go back to this equation. Are we improving the value of care? Well, value is quality of the outcome over the cost of the intervention. And for spinal fusions, maybe we've changed the quality a little bit. We've decreased some back pain. Maybe we've decreased the length of stay, but not tremendously. These kids aren't a lot better than they were in the late 90s and in the late 80s and early 90s. And we certainly have increased the cost of the intervention over time. So just stepping back and looking at it on a sort of basis of looking at it from 1,000 feet, no, we've decreased the value of care is what we've done. And so we have to do this on a small level. How do we change this? Okay, that's the task for today. And I think that's what Karen's going to talk about here next.
So was everybody here last week? Yeah, it was a tough act to follow, right? That was fantastic. Yeah, I was getting a little nervous in the audience last week. This, of course, the triple aim, I think if you take a step back from value, which we all talk about, the idea of the triple aim was introduced in 2008 by Don Berwick, who, of course, was the head of the IHI for quite a long time, and really a fantastic speaker. We did try to get him, but you're stuck with Matt and I. I'll actually show you a little video of him talking about this, because he's very, very common sense, down-to-earth speaker, despite being very erudite. So the idea is really that you want to have a better patient experience, you want better health care, but at lower cost. And that, of course, is the triple aim. And that's really where, like I said, the value conversations we have come from. I'm going to see if I can get this to load up in a reasonable amount of time. My 15-year-old stepson functions as my tech consultant, and he is absolutely awesome.
The triple aim is a concept that tries to capture the social need from healthcare. What are we here to do? And it says that the accomplishments society needs from healthcare are first, better care. So if you get sick, all of the dimensions of improvement that are described in the IOM report, Crossing the Quality Chasm, are brought as close to perfection as possible. Safety, effectiveness, patient-centered care, timeliness, efficiency, equity, great care. But that's not good enough. The second aim is better health. And that's not really achieved through the care system. It means we have to work on the causes of illness, obesity, substance abuse, inequity and poverty in society, the kind of sedentary lifestyle we become accustomed to. So it's achieving better health. And the third is doing all of that at lower cost, not by withholding what people need, but lower cost through improvement of the processes of care and the processes through which we prevent illness. The triple aim, better care, better health, lower cost. That's what society needs us to focus on.
All right. So when you look at the current did I miss something yet? When you look at the current perioperative care, a slide that will come back in a second is actually from a New England Journal article. It's an adult patient model, but it is a patient that had a gallbladder or a bile duct tumor, and it's the process by which he got to surgery, which took 80 days, and an extraordinary number of interactions via phone call, procedures, email, maybe texting if it was a little more modern. And you can see that a lot of this is coming from the patient's PCP, from the internal medicine doctor. And so when we talk about how to do perioperative care, one of the things that we talk about if we're talking about a medical home or a surgical home is who's really in the position to do that. And I would ask you to kind of imagine, especially if you are in training, yourself in a few years out perhaps in the community or even in a hospital base, if you're really in a great position to be able to shepherd that patient through a complex procedure. So if we wanted to create a more idealistic model of perioperative, we would introduce a concept like the perioperative surgical home. And the language, I think, is deliberately similar to the medical home in that it's to be patient-centric, it's to involve care coordination, and it's to shepherd the patient and family through in a truly organized fashion. And so what it introduces is the idea that the surgical care doesn't begin when the patient checks in across the hallway for their procedure. The surgical care begins when they sit in Matt Oetgen's clinic, and he says, you know what, your curve is 52 degrees now. It went up 12 degrees in the last 3 months. You're right when you saw a change. You came back in. Really, you're at the point where we would recommend fusion. So the idea, even maybe before getting a surgical date, that we should begin to care for you in a different environment. And in an ideal world, the pediatrician or the patient medical center home would pass off to the surgical home, and then at the exit of the procedure, when they've left the hospital, when they've come back for their surgical follow-up, when they've had no complications, we would hand the patient back, hopefully with all of the information that the pediatrician and the family would like to know about the surgery in the future. And I highlighted surgery in the middle, not necessarily because it's the most important thing, but because I think it really shows the amount of work before and after that's done, and all of the areas that we tackled by creating the surgical home for these specific type of patients, the idiopathic scoliosis patients having the surgical home. And we, having spinal fusion, and what we did was we pulled in blood management, we pulled in patient optimization, we pulled in patient education, we worked with our physical therapists and our pain management specialists, we looked at what type of support patients and family need after discharge, and we wrapped it up all together. And I think in a simplistic way of saying it, what we are trying to do is to provide the type of care you would want your child to receive and the type of experience you would like to have if you were having this major surgery. And again, really, I think what you're trying to do is to incorporate the triple aim into surgical care. So we want to improve the individual experience with the surgical care. We want to improve the health of the surgical population, and we want to reduce or at least control the per capita cost of surgical care. So we're going to talk a little bit nuts and bolts about what we did here because I do want it to be translatable to you. And we started about a year ago at this time last year in October, and we really gathered the stakeholders, which I think is a very important process. You have to identify everybody who really has their hands on the patient. And what I'd like to do is share with you the idea that Matt and I are up here talking about this program, but an extraordinary number of people put a lot of time and effort into this program, and I think that is really some of the fantastic part of it that made it so enjoyable and partially why we've had such good results. And I'll just try to give you a few examples. Our physical therapy team did some really amazing work. For example, they actually changed their staffing model. Their leadership made a fiscal argument as well as a patient care argument and went through workforce management, and physical therapy is not in the hospital 7 days a week. It used to be 5.5. They came Saturday mornings. And we found there was really no way we could get a patient out of the hospital on Saturday or Sunday if you have to pass physical therapy and no one is here. And it really stops recovery. So that's something really fantastic that they took on as a group and took forward to their leadership. The other thing that they did is they actually initiated and designed a patient education class that they do in turn partnering with orthopedic nurse practitioners. And they do this one evening a month. It's kind of a freebie, and basically what they do is they go through all of the things that we know we've told the patient but has been unable to absorb, and they go through them in detail about what the recovery will be, and they actually physically practice with the patients how to get in and out of bed and with their parents with spinal fusion precautions, which most of us probably don't think of because we're not orthopedic surgeons, but the patients can't twist and they can't bend for a while. So they teach the parents how to help the kid get out of bed, and we do this before they're in pain and anxious after surgery. And they've gotten tremendous patient and family feedback on this type of work. And I'll tell you, the PACU nurses love this because they say they can tell the difference between a patient who went to the class and a patient who didn't, because they said the patients who go to the classes, they wake up a half an hour later, they're like, oh, I'm uncomfortable, I want to move. They put their arms over their chest and they log roll. So that's just an example of really, I think, each group here, or our nursing team, our PACU nursing team, agreed and trained to take these patients out of the ICU so we could handle them in a different level of care, and that was a big leap of faith for them. Our surgical care nurses agreed to come in an hour early and flex their shifts. They come down to the PACU and receive the patient so we can do an ideal bedside handoff, physician to physician and nursing to nursing. Our anesthesiologists, we standardized our care completely, and let me tell you, that is a hard thing to do. We like to think of medicine as an art form, and it is, and we don't like to be told what to do. But as one of our very, very lovely anesthesiologists, I don't know if any of you know Sarah Reese-Stram-Tam, she's also on the pain service, one of the nicest people you ever meet. And what she told me about this after we started was, you know, Karen, I really hate being told what to do, but damn it, it worked. So, you know, I think a lot of people took on a lot of change here and really embraced it, and it was absolutely teamwork, although Matt and I are sitting up here, you know, talking to you about it. The next thing that we did after we had this humongous group of people in a room is you realize that that's pretty ungainly to get any work done when you have 50 people in a room, and that is a very painful meeting to attend. So we divided into 4 teams, and we did it in terms of time basis. We divided into a pre-op team, into an operative team, into a hospital stay team, and into a discharge, post-discharge team. And in each one of these teams, we had a spinal fusion surgeon. We have 4 very conveniently. So we had 100% buy-in, which was great. And in each team, we had an anesthesiologist. We had nursing represented, administrative folks. And we used our project management folks from Transformation 2018, who I say were absolutely invaluable, and we would never have done this on the timeline that we did. We did a Lean Six Sigma mapping through the entire process, from the patient sitting in Dr. Oetgen's clinic until they're home safely. Now, I include this slide not because I expect you to be able to read it, but because if you've never seen a Six Sigma map, this is what one looks like. And to, I guess, kind of show you the actual significance of the process, our map turned out to be 6 pages. We had 79 storm clouds. I'll read a few of them for you. There's no standardization for when the urinary catheter needs to come out. 59 is missed, need a Foley with a PCA. No standardization of PCA and pain management. So one way that I may have stressed out our project management folks is they say, you know, traditionally in the lean process, you make one change and then you see what happens. And we kind of blew that out of the water. So what we did, again, in our smaller teams, is we dove deep into the literature. We found evidence-based care where we could find. Where the evidence was not really sufficient, we agreed as a group to best practice standards. And everybody did buy in, and if you wanted to be a part of the care of the patients, then you bought into following the protocol. And I do think the standardization is key. As Matt likes to say, unstandardized practice leads to unstandardized outcomes. And the other thing that's key is, I think, in addition to actually just having a pathway, you need to make sure that things happen again and again. And so what we did was we embedded them in Cerner order sets. So we created Cerner order sets. We put them through the OSOC committee, which, as you know, is not an easy process, but was very helpful and effective. And we created 2 standard order sets. We created a separate pain order set for PCA for a patient having spinal fusion, and we created an orthopedic order set. And what that did, like I said, is really embedded our care changes to make it harder for us not to follow the pathway. And this just represents some of the changes that we did, and again, that relationship where the patient is entering the surgical home. Some of the changes we integrated come from an adult-based program called Enhanced Recovery After Surgery, which originated in Europe about 15 years ago in adult colorectal surgery, with some really common sense ideas bundled together in like a 14-point bundle. And that includes things like early mobilization, decreased fasting, using non-opioid pain medication to reduce side effects, and bowel ileus. And you can see here we standardized our care throughout. We looked at our blood management or our blood utilization, and Matt Sharon and Matt Oetgen had done some great work to reduce our wastage of blood. So we used to match 2 units. We now match 1 unit. We offer every family the opportunity for autologous blood if they would like to do that. We standardized when they were getting our iron. Again, we introduced this pre-op class. We also introduced a patient database to try to reduce the number of confusing communications and emails where we track our patients' labs, we track their MRI, we try to avoid any delays or cancellation in the process. In the OR, we introduced a concept called goal-directed therapy, which is really the idea of using less IV fluid with a lower sodium load and less of a volume load. We standardized our cell saver. We standardized our intraoperative anesthesia and post-op anesthesia plan. We introduced IV Tylenol and Toradol and Valium. And again, really post-operatively standardization of care. In order for the patients to come out of the ICU, our anesthesia team agreed to co-manage them the evening following surgery in the PACU, and our PACU nursing team agreed to keep the patients in the PACU. And our surgical care nurses agreed to come and take them from the PACU at 6:30 in the morning before the elective cases start so that we can keep everything moving. So post-discharge, what we found is most of these kids actually do well. We have a low readmission rate. So we address the things that cause the most anxiety and the most number of contacts to orthopedic team, which was addressing removal and pain management. Once you gather together and you make all of these changes for implementation, I think communication and education is key. You have to go back to everybody who has boots on the ground and explain to them why you're doing what you're doing, get their buy-in, allow them to complain a little bit if that's part of the process, maybe make a few changes, and then you implement. And we implemented this in March of 2015. I think the next important steps are to incorporate some debriefing. For example, after our initial patients, we had a team, it was usually a phone call debrief, and particularly after we moved the patients from the ICU to the PACU, which was about 6 weeks after this March 15th, we had a meeting and we discussed like what didn't work in the order set, what problems were there any safety events, and then finally we stopped and looked at our data, and that's we're also going to share with you. I think it's important when you look at success or value, what are you measuring? So we looked at our primary outcome measures as length of stay, still having good surgical safety outcomes. ICU utilization was definitely a goal for us, and then costs. Additionally, I'm going to move patient satisfaction over because I think that really should be a primary outcome measure. Unfortunately, we did not independently measure this, and we don't have enough Press-Ganey data to really give us that specific measurement. Well, that's a little leading, but so when we look at length of stay, we really had some fantastic results, and we're very excited by this. Our 5.12, 5.2 days is really the national average when you look at freestanding pediatric hospitals. So it's not as though we were, doing terribly before, but now our patients go home between 3 and 4 days. So a pretty big change, and they're ready to go home, and they're better faster. When we look at our ICU utilization, when we introduced this other pathway, we went from 100% ICU utilization to 16% ICU utilization. We've had one patient who, for a medical reason, who had a transient AV block in the recovery room that I think was really unpredictable, went to the ICU unexpectedly, but other than that, the people who've gone there, we've scheduled to go there. And finally, when we looked at our perioperative blood transfusion rate, so that's the whole episode of care in the hospital, our blood transfusion rate went from 35% to 11%. Now, this is the pre-number is about 115 patients, and the post number is about 30 patients right now. So it is a relatively small sample size, and there could be some error introduced in there, but it is statistically significant. Since we are an academic institution, I'll throw that in. So then the question, I think, is you really cannot talk about value without talking about money. So what happened financially with this? So from our perspective, we looked at the decrease in total charges. There are, of course, a difference between costs and charges, and cost accounting is pretty complex to do, pretty sophisticated, so a lot of times people will use total charges as a little bit easier caveat. Additionally, when we looked in the literature, the benchmarking for scoliosis is pretty consistently done in total charges, and basically we decreased our total charges by about 10%. Now that may be complex when you initially look at it and think, well, you knocked down your length of stay by 35%. Why did they only come down 10%, and that's because of the things like the surgery is really the most expensive part of the care, and as are the implants. So that aspect of things we're not changing so much. How do we do compared to other people? And I think there's two types of benchmarking we do here at Children's. To my understanding, I am a clinician, not an administrator, but we benchmark ourselves locally in the community, and then we benchmark ourselves to the pediatric freestanding hospitals, mostly by the FIS database. So the orange over here marks the pointer. Marks the FIS database from 2012. And you can see our baseline in the red in 2014 and 2015, we were already below national average, and then we took 10% off of that. So interestingly, it's very regional. It's much more expensive to have a spinal fusion in the west than it is in the south. So we kind of probably come out somewhere in the middle / leaning towards the south. So I think, once again, now we've talked about money and quality. Let's go back and look at the value equation again. So if you ask the question, did we improve the value of care? We did improve the quality. We reduced the length of stay. We reduced ICU utilization. We reduced blood transfusion. We've had no readmissions. And although we didn't show you this data because I think it is a bit anesthesia and surgery specific, we did reduce opioid consumption with stable pain scores. And finally, on the denominator, we decreased our charges by about 10%. So I think the question that clinicians often ask is, when is the right time to do this kind of work? And I don't think any of us really knows the answer. I've had the privilege of being part of the national collaborative through the American Society of Anesthesiology about the surgical home. The collaborative is also run by a premier consulting group, so I've gotten a chance to talk with a lot of people who do know more about this, and it's been quite interesting. And I think Matt and I have a little bit of a unique perspective in that both of our specialties, anesthesia and surgery, really cross between adult and pediatric, unlike the pediatric specialties. And the surgical home movement is moving quite a bit faster in the adult world. And from my perspective on thinking about this, I'm not sure it's because our patient populations are so different as it is our payers. So when I talk to my friends who are doing a total joint, hip and knee surgical home across the country, they're 50-50 private payer Medicare. We're 50-50 private payer Medicaid. Well, what's the difference between Medicare and Medicaid? Medicare is a nationwide program that is standardized, highly organized, and is introducing bundled payments for surgery. Not only is it innovation, but in January of 2016, they're introducing bundled payments for total joints. And there's no application for the process, meaning it's happening. In Medicaid, it varies by state, right? Here we have 3 or 4 different plans in DC, 3 in Virginia, I think 4 in Maryland. Each of them is independent. They independently contract with us. The other thing is that, say you look at Washington, D.C., and you guys may know all of this, only about 50% of patients in Medicaid in Washington, D.C. are pediatric. 50% of them are over the age of 26. The highest problem of readmissions for Medicaid is actually adult readmissions. It's actually, I think, adult psychiatric readmissions. So Medicaid is not quite as focused on bundling care for surgery. I don't think that means that we shouldn't do the work, but I think it explains why it is not as much of a driver. So if you look at how we actually do get paid, right now, and again, this is a clinician's perspective, there's what we call traditional contracts, which are per diem contracts or percentage charge, and they're kind of what they sound like. Per diem, we get paid a certain amount per day. Percentage charge, we get paid a certain percentage of the total charge, versus a DRG-based payment. In pediatrics, we use the APR DRGs because the original DRGs don't have any pediatric coding. And for example, idiopathic scoliosis is DRG 303. So all of our patients are coded under that. And the idea would be that we would get a lump sum payment based on the patient's DRG code with some modifiers. And the modifiers are the fact that the patient has scoliosis or neurofibromatosis or asthma. And that's the reason why our coding is so important, because those modifiers do increase the payment. So if you have more of the traditional payment methods, per diem, if you get paid by the day, and we change from 5.3 days to 3.5 days, something not great is going to happen financially. If we get paid by the DRG, we've created an opportunity. And for example, with a reduction in length of stay, we created an opportunity throughout the annual year of about 160 bed days. And if you think about that, given how frequently we've been on high census in the last year, that's actually pretty nice. Gives us a chance to get another patient in the bed, gives us a chance to function like normal human beings instead of on high alert. We may even take better care of patients. So there's an opportunity cost in addition to a financial cost here. So I share very cautiously with you, as their financial folks have told me, because reimbursement data is really inconsistent. I think of it very simplistically as the parent of a preschooler too, which is like you get what you get and you don't get upset. So you don't necessarily know what's going to come out. But when we looked at our first 20 patients, actually, despite the fact that our charges are down, our reimbursement is up 3%. Now, I will say with several caveats, our payer mix was not exactly the same year over year. We did cross a fiscal year, meaning the charge master adjusted our charges a little bit, and it may be that the next 20 patients, this will not look, as good. But I do think it's important to share because a lot of us feel like, well, we shouldn't be doing this work yet. And I'm not sure that that answer is clear. I don't know if it's going to be the same for every population we look at, but I think we can say it's non-inferior. So on a broad level, what are we looking to do with our surgical home? We are really proud of this program, as you can imagine, and we really feel good about the amount of, or the type of care we're providing to our patients. So what we'd like to do, Matt and I and the rest of the team, is to expand it. So we're working with our PR and marketing rep, Tucker Petty, and the rest of the team to see how we can go back out to our referring providers and how we can get directly to the patients and families, because we think we take better care of these patients with idiopathic scoliosis than anybody else in the region. We're looking at it as opportunity for development, and I saw Brian Jacobs walk in. His face gets a little pained when I tell him what I'd like to do, but what I've seen when I look across the country is everybody's trying to make their software system help them with these patients. And so I think what we'd like to do is partner with either other hospitals or Cerner through the Bear Institute to create something that will really help across the entire episode of care, as opposed to our current EHR, which really is very specific to the day that you're in the hospital or the current episode of care. So I'd love to replace my Excel database with something within Cerner that lets Dr. Oetgen track all of his patients that are coming to surgery if they had their MRI in their labs. I'd love to track everybody in the surgical home that's in the hospital and to know when their pain scores go above 4, and we should do something about it. I would love to have an alert when the Foley doesn't come out when it's supposed to. I would love to be able to push the video that we made of how to remove the dressing to the family on post-op day 7 when they're at home, remind them to take off the dressing. They watch the 90-second video, they go and do it. Ideally, I would love for them to take a snapshot on their iPhone and send us back through the patient portal the snapshot of what their incision looks like to know, do we need to get them in sooner than their scheduled appointment. So those are some of the things that I'd like to see, and I can guarantee you that if we had this or if Cerner had this, that any Cerner hospital in the country who's implementing the surgical home would love to have it too. And the last thing is that we would really like to grow this academically. I think it provides a really rich environment for us to do research on pain. When we look at our pain scores, for example, we still see outliers who are using 2 or 3 times as much morphine as everybody else. Why is that? Is it something, patient personality characteristics? Is it something in the way they physiologically process the pain medication? Can we identify them ahead of time and do something differently? And it gives us a lot of opportunity for collaboration. I've had some fantastic conversations with the people at Texas Children's, with the people at CHOP, with the people in Denver about what they're doing. That's really satisfying personally, and it gives us a lot of opportunities for growth. And then finally would be, what can we do with this model here at Children's and nationwide? One thing that I think does pertain very specifically to hospital-based or pediatricians is how do we all work in this together? And one of our strengths here in these relationships at Children's is I think we developed collaboratively. We did not develop competitively. For example, when we opened the Perioperative Care Clinic, the POC clinic, about 6 years ago, with Dr. Newman's support in the surgery center, it was a joint project between Miriam Bloom and I. And Miriam was coming from complex care, going into hospitalist medicine. And she had been taking care of the kids that had a spinal fusion through complex care. And they really were having a lot of difficulties, mostly with tracking patients' outcome care coordination. And we merged those two programs, which led to the hospitalist seeing patients in the pre-op clinic, as well as co-managing some of them post-operatively. So I think what we need to do is figure out what everyone's strong suits are that bring to the game. What does the anesthesiologist know about the patient, and where can they add to it? What does the hospitalist know best about the patient, and where can they add to the patient care? And how do we all get on the same page and work together as a team? In terms of care models, we are looking currently in this fiscal year at our patients with sickle cell disease, and that would be regardless of the procedure they're having, if they're having a TNA, if they're having a lap splenectomy, if they're having a lap chole. With Pranav Sinha and Jamie Schwartz and Nina Deutsch and John Berger, we're looking at our adult and adolescent congenital cardiac surgical patients. And we're looking at our Nissen and G-tube patients, and that will directly involve the hospitalist teams because we do have this co-management agreement, but what we've seen is we also have a widely variable length of stay, and that's what makes those patients a great target. They come in for a scheduled surgery, and some of them stay 2 or 3 days, and some of them stay 16 days. So there's definitely an opportunity for benefit there, just like there was an opportunity for benefit with our otherwise healthy kids having scoliosis. So I included an acknowledgement page because we really had an astonishing amount of support and help from people in all sorts of different leadership teams here, for which we're very grateful. And I've tried to leave enough time for any questions. Yeah, I think we're going to let Tony be the MC.
Yeah. I feel like I shirked my job initially. It's very unusual to introduce speakers after the fact, but you often say, oh, I'm really looking forward to your talk. No, I can't say that, but I really enjoyed the part of the talk that I saw. Just to give you some background, first, Matt Oetgen, for those of you who may or may not know him, Matt did his pediatric orthopedics at Scottish Rite Hospital, and now is our chief of orthopedic surgery here at Children's, and he was just appointed maybe a year ago, 6 months, and it's really been terrific with his leadership, as you can see clinically, and his leadership academically. I really think our orthopedic program is poised to be one of the best, and this is just a small tribute to that. Karen, of course, let me tell you a little bit about Karen. She did her cardiac and a pediatric anesthesiology fellowship at Boston Children's and started the POC, as you mentioned, the Perioperative Care Center, about 6 years ago. And that was when Kurt was in my role. Karen would come to my office when I took over the job and say, we need this for the POC, we need this for the POC, we need more nurse practice. And I kept saying, no, Karen, we just don't have the budget. No, no. And eventually she came and she asked me about joining this collaborative. And I said, if I say no to one more time, I think she's never going to speak to me again. So I said, oh, all right, Karen, go ahead and do it. And I really wasn't completely taken by it. But now, having seen and understood what the whole process is, fortunately, I turned to Susan at the time, and Susan said, well, whatever. We really did stumble with Karen's leadership into something really significant. And I think this really is planned cares on steroids, and really is going to make an incredible difference to the patient care that we deliver at Children's. So I really congratulate you and thank you both for this incredible effort. As you can see, there was a lot of work involved in this. I'd like to open the floor to any questions or discussion. Steve, you got the...
Hello? 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 Hello?
There we go. So congratulations, Matt, Karen. That's really an out-of-the-park home run. I'm very, very impressed, as I think we all are, and I think the opportunity to study this and to disseminate it is huge. I have one, however, I have one huge concern. Matt mentioned early in his presentation PCORI and the Patient-Centered Outcome Research Institute, and one of the real principles of value-based care is patient engagement, stakeholder engagement, and the patient voice. And in the development of your surgical care model, I didn't hear anything about the patient voice, about the parent voice, about focus groups, key informant interviews that could have conceivably informed this process and made it even stronger by asking the families what they needed and what they wanted. And in your outcomes, again, you mentioned this, Karen, and I think you're right. It's hard to do everything, especially when it's unfunded, but I didn't see the patient voice evaluated. I would argue that you created a very children's national-centered model instead of a patient-centered model. And I just want you to comment on that. It's a provocative question, but I ask it with the best of intentions.
Yeah, sure. I think we did incorporate what providers were hearing from patients and families and what our interactions were with them, but we did not incorporate them into the design process, and I do think that's something that we could do in the future. We looked at things like what were the most frequent reasons after discharge for them to call, and we've tried to kind of get ahead of that, if you could say. We worked with our child life teams to develop some like game boards and other things like that. You know, I do think what it sort of touches on is some of the debate in medicine, although I think it's more in internal medicine, the idea that our outcomes related to patient satisfaction scores. So, you know, I think it's a very valid point and a question that you raise, and it is something we can do to strengthen the program going forward, and it's something we can do a little bit better the next time we, you know, come around. But I would hope that to some degree what we want and is what patients and families want, which is they want to get better faster, they want to be treated well, they want their care to be coordinated, they want to know what to expect. We do these patient handoffs at the bedside so they can be incorporated into them. For example, the handoff from the PACU nurse to the floor nurse and the handoff from the attending anesthesiologist to the attending surgeon takes place at the patient's bedside to incorporate the family into some of those decisions. The people who did do patient satisfaction actually were the physical therapists, and they collected that from their preoperative class and have incorporated that in, and those actually were very helpful and fantastic to see. So,
and let me just add, we know that too, and we've kicked ourselves a little bit in private to say, I wish we had the patient outcome data and we should have set that up. But as you say, it's hard to make a change and it's hard to make a grand change. But we have sort of as we move forward. So as we implemented the preoperative clinic, we've gotten feedback from patients, and as we've gotten some funding, we've tailored that into some of the things that we hear. So what are the things that stress you out? Well, it's really stressful to change the dressing. So we've made a video of how you change a dressing, and we've rolled that out to the patients. It's really stressful to get their kids up when they get home, and now there's a video to understand how to do that. So we've been able to develop some tools to help some of that, and we've gotten feedback. And I think that as this grows, and this should be sort of a thing that grows, it should get better in that vein.
So, go ahead, Mark. So first of all, congratulations both on the work that you and your team have done and also the terrific talk. I wanted to riff on three aspects of what you spoke of for the general audience. First, there was a mention early on by Matt about PCORI and then subsequently by Stephen, and all of you may not know about this new opportunity, but I want you to be aware of it. So this is a new institute that's not the same as the NIH, but that is giving out every year $450 million in grants for patient-centered outcomes research. And Dr. Teach is the principal investigator of one of the 4 different PCORI grants that we currently hold. And you ought to think about that in your own practice as to whether there are questions where there are 2 different types of treatments or trying to improve treatments where you would actually include patients in asking the questions and doing research. A lot of money available, really important research questions to be asked, as Stephen spoke of. Secondly, with regard to value-based care, we actually are in negotiations now, or going to be starting negotiations about population health. You know, historically the model has been fee-for-service, and it's headed with the ACA towards population-based health, where we would take a whole population of children and get a certain amount of money per year to treat all of these children. So if it costs us less to treat a child with scoliosis, that's good not only for the family, but also for our financial health. So this whole issue of value-based care is going to become very important for all of your practices, and the idea of a medical and a surgical home is really the way to do it. And the third was with regard to lean. We actually have a whole program here where you can get an idea of how you would use the lean precepts to do your job better. And you can apply to have the lean team come in and help you, as they did with Karen and Matt, to do your job better. So I think that this presentation represents all three of these areas which you could apply for your own work.
So Karen and Matt, I just want to applaud you for the great work that you're doing in this whole value-based care delivery and population health, and particularly as it applies to a surgical pediatric home. I think that's just so on the edge and innovative in this land of adult care that we live in. So I had two questions. When you think about population health, your start point is when they hit your clinic. So I'm wondering about backing up the needle a little bit. What about that kid who gets screened in school, the community pediatrician that really sort of closed the loop? Because when you think about it, we have a very small wedge into the health of the kids that we take care of. When they hit your clinic, they hit the ED, and when we send them home, we don't really spread that wedge out. But one way to think about that is to get out into the schools where they're doing scoliosis screening, where we employ the nurses and we actually house their electronic health record, as well as in the community pediatric offices that are part of our organization as well. Just wondering about your thoughts about spread into that area.
Well, that's a good question. I mean, it's a bit of a hornet's nest because, you know, if you talk about school screening, then, you know, the U.S. Preventative Task Force 10 years ago came out with a statement that says no more school screening. It doesn't work. We recommend against it, okay? So AAP, the Orthopedic Society, Scoliosis Society says, yeah, we got to keep on doing this. And we've just submitted an abstract looking at sort of how that does. And what school screening does is it saves about 350 spinal fusions a year in the United States, but it costs about $50 million extra, okay, because of the cost of the screening. So you start to get a little cost-benefit ratio there. But I do think taking a step back to the pediatrician's office would be very helpful, because another study we did looked at the variability in resource utilization in the kids that are getting referred to us. And we saw a tremendous amount of kids that were getting x-rays that didn't have any ability for us to change our management before they got to us. And if we can get some of that education out there to say, no, this is the way that you sort of standardize your evaluation of patients that would make it more effective, less costly, then we'll start to affect that a little bit down the line. And the way to do that, I think, is to get the AAP and POSNA and the SRS to start to use some of their task force to get it out to the community to say, here's a standardization of care, of evaluation, which will decrease some of the costs. But I think that that's a good way to do it.
And I think there actually may be a little bit of a different benefit when you look at different populations. For example, if you look at the neuromuscular scoliosis population, a lot of them are cerebral palsy kids, and I know they're doing some interesting work looking at kids coming out of the NICU and following them through. And what we see for cerebral palsy is we see them quite a bit in the operating room, as you can imagine. We see them for G-tubes, for Nissen and G-tubes. We see them for Botox. We see them for hip osteotomies, and we see them for spinal fusion. When we fuse them, sometimes we fuse them quite a bit later. We fuse them at 90 to 120 degrees, when ideally we'd probably want to fuse them from 50 to 70 degrees. So it may be that we are able to change resource utilization at times by coordinating the care more on an institutional basis or community basis, and that if your length of stay is shorter, if you get fused at 60 degrees, then that might be the time to do it.
had one other question if no one else has any. So, and this is a little bit on the devil's advocate side. So when the residents used to ask me in the ICU, why are we putting these spinal fusion kids in the ICU, the standard line was, well, now and then these children will lose neurologic function and have spinal cord paralysis. And you need to do every hour neuro checks to pick that up. And then every now and then you're going to get a child who bleeds and gets hemorrhagic shock, and you need to follow their drain output and their hematocrits and see what's going on. And also we're going to follow their pain, and we need to make sure we manage their pain. So those three things, not the latter, but the first two, the cord paralysis and the hemorrhagic shock, is unusual, but anybody who's been doing this for 15, 20 years has seen one or two or three of these. So with a case number of 30 thus far, how do we know that we're not going to miss some of those by post-op PACU management as opposed to post-op PICU management? What sort of safeguards are in place there?
Well, what we did actually was we did have one of those in the last 18 months here at Children's, which was properly treated by raising the patient's perfusion pressure, their blood pressure, and they had returned to neurologic function before they went back to the OR to pull out the hardware. And that was able to help us, as well as a consensus paper put out by some folks in POSNA, the Pediatric Orthopedic Society of North America, to create kind of a standardized checklist and plan for how to handle that. We incorporated that into both our intra-op and our post-operative plan so that everyone knows who is to do what should that happen, including like who you need to patient alert, what medication we're going to start, where the medication is located, whose job it is to mix the medication, all of those type of things. So I think actually it gave us an opportunity to improve our potential response to that regardless of where the patient is physically located. And in our care set, which Jeff Hanway and Sophie Pestu spent an enormous amount of time on, we did translate those portions. The fact is that the PACU is an intensive care type environment, and we are capable of doing things like frequent neuro checks. So we created within our care plan for nursing and physicians the safeguards. So we still do hourly neuro checks.
Thank you.
If there's no more questions, I'd like Karen just to make an announcement about a speaker tomorrow.
Oh. Yeah, so tomorrow is actually our annual McGill Lectureship, which is an endowed lectureship based on a fantastic man who was a chairman here for a long time, or chief for a long time of anesthesia. And the speaker is a man named Zeb Kane, who's really the clinical leader in the surgical home movement nationwide. He's a fantastic speaker, again, very down to earth. And although he is the chair of a large mixed program of adults and pediatrics, he's actually a pediatric anesthesiologist by training, was at Yale for a long time and has had continuous NIH funding since 1986. So really a fantastic, maybe 96, really a fantastic guy. And he'll be speaking in the traditional anesthesia grand rounds tomorrow, which is from 7 to 8. So I would really, welcome you to join us as well.
All right, thank you very much.